Hello, my name is Greta Greer. I'm the Director of Survivor Programs at the American Cancer Society Corporate Center in Atlanta, Georgia. As an oncology social worker, I'm especially pleased to make a few introductory remarks about this year's American Cancer Society Quality Life Award recipient, Roeliena VanZanten. Roeliena graciously agreed to travel to Atlanta to videotape the presentation she gave at the 2014 AOSW conference in conjunction with the Quality of Life Award. You'll be seeing that in a couple of minutes, but first I want to share with you a few highlights from her bio. Roeliena was born and raised in the Netherlands. She began her career as a special education teacher working with juveniles in group homes. She went on to earn a doctoral degree in andragology from the Free Reformed University in Amsterdam in 1980, with specializations in social medicine and group dynamics. Roeliena immigrated to the U.S. and obtained a master's degree in social work from NYU School of Social Work in 1986. She held various positions at cancer centers and nonprofit organizations before going into private practice a few years ago. Roeliena has vast knowledge and practice experience in helping cancer survivors and families address their quality of life issues. Many years ago, she developed a special interest in helping healthcare professionals address their quality of life issues as well. She's highly engaged in and committed to helping us all learn and practice self-care. Roeliena has contributed much to the field of oncology social work and to AOSW, and is deeply attached to her identity as an oncology social worker. On a more personal note, I want to say that Roeliena is one of those special people we meet in life whose inner beauty can't be missed, even in a brief encounter. She has a calming presence, gentleness, acceptance, and compassion that come from her very, very large, open heart. It's a pleasure and an honor to introduce this videotape of the 2014 American Cancer Society Quality of Life Award lecture given by Roeliena VanZanten, our award recipient. The title of her presentation is Quality of Life for Oncology Social Workers. Who cares? Occupational health, distress, and self-care.
This is a presentation about occupational health issues for oncology social workers. If you find this useful, feel free to contact me at the email provided here on the page and use any of the information as you see fit in your own setting. But first of all, I want to give a very special thank you to the American Cancer Society for sponsoring the Quality of Life in Cancer Award, which inspired me so much as a recipient to put together this presentation about quality of life for oncology social workers. A number of times during my career, I've had to rebalance my work and personal issues, and from time to time also questioned whether I was in the right career. This topic has always been of interest, and my conclusion has always been that I was in the right career. People enter this profession, I think, for a reason that is strongly related to an affinity to help others. And I found this quote by Winston Churchill, which very much applies to this principle. We make a living by what we get, but we make a life by what we give. It's all about service. And it is also about another concept, compassion. At the root of our work lies empathy and compassion, and I found two definitions. This first one by Henry Nouwen is more existential, spiritually based. Dr. Nouwen wrote a lot about the wounded healer. Compassion asks us to where it hurts, to enter into the places of pain, to share in brokenness, fear, confusion, and anguish. It challenges us to cry out with those in misery, to mourn with those who are lonely, to weep with those in tears. Requires us to be weak with the weak, vulnerable and powerless with the powerless, and means full immersion in a condition of being human. When I look at this, I see the parallel process he alludes to, something that was very eloquently described in oncology social work by Hester Hill Schnipper in the 90s. in an article called Point and Counterpoint. For your reference, there is a bibliography on this website, and you will find some very helpful materials there. The second definition of compassion is more applicable to the helping professional because it implies the notion that certain skills and other qualities might be needed. This definition is by Dr. Stam, who worked closely with Charles Figley in the 90s and to this time, and he especially provided significant research in the area of compassion satisfaction. We'll address this later on. We've come a long way in our profession to look at distress in our patients, and we even have come to assess distress to such an extent that we've been able to develop guidelines for staffing. However, this field of distress among our own selves is very underdeveloped. And maybe this has to do with the fact that we often take a self-sacrificing stand in our career. Perhaps we are less comfortable talking about our own distress. But let's look at the components of occupational health, distress, and self-care, and some of those will be readdressed as we proceed. There's personal lifestyle choices to make about whether a helping profession is a fit for us or not, personal motivation, professional guidelines and ethics, organizational managerial responsibilities, and then we have a whole education piece in academia and workplace adaptations. Only in 2004, about 10 years ago, the National Association of Social Work developed a workforce study program addressing some of these components and issues, and starting to pay more attention to professional well-being and self-care, especially in social work and healthcare. Just a half year ago, they came out with the book Self-Care for Social Workers, one of the first. Let's look at the NASW Code of Ethics for a moment, because it gives us some information about our personal function. This text is mostly written from a liability issue, but if we reframe these, it really means we need to take care of ourselves emotionally and mentally. There's two things that are really important in the Code of Ethics. One is that the interference of personal problems, distress, and mental health difficulties is a serious matter that needs a response. And the second component is that the response needs to come both from the worker themselves and from colleagues who recognize that there is an impairment and to assist their colleague in immediate remedial action. From the same Center for Workforce Studies, in a study of 2008, some major work-related stressors in social work were identified. The percentages in red are for social workers in healthcare. Just as a reminder, in healthcare overall, not specifically in oncology, and so there might be differences. However, we don't have any of these numbers available in oncology social work. When you look at these stressors, most of it is related to organizational and environmental factors. And this matches some of the anecdotal information that comes out of our own membership and also out of topics that are addressed on SWAN. In 2004, the same organization did another research project, and it was learned from that it wasn't clients causing the distress mostly, but the work environment itself. So if we spell out the major categories in stress-related concerns in that same study in healthcare, the people interviewed said, and this was the large group of members of NASW, 36% psychological problems, 70% stress-related fatigue, and 23% sleep disorder. I think the interesting part about these percentages is that they resemble a bit the stress factors in oncology patients, especially the fatigue and sleep disorders. Again, this is for social workers in healthcare in general, not specifically for oncology social workers. Also, these numbers do not add up to 100 because there were various categories people could choose from to report as a stress factor. In a very nice study, exploratory study based on interviews with various members of the oncology team, Rohan and Bausch identified self-described challenges and rewards by oncology clinicians. And this was based on clinicians of all disciplines. Challenges that were noted in that study, and it appeared in the Journal of Psychosocial Oncology, were boundary issues, medical issues, psychosocial, potential for mistakes, and the nature of the healthcare system. Looking at rewards, the interviewees reported ease suffering, received gratitude from patients, emotional connections, and being inspired and in awe of the human spirit, gaining wisdom and perspective. They also mention that teams were frequently mentioned as a buffer against inherent challenges, especially cohesive teams and mutually supportive teams were mentioned as facilitating satisfaction and rewards in the work. So what are the themes that oncology social workers face? And these are various themes that I picked from going through what AOSW membership brings up in SWAN and in the literature. Intensity of emotions, a reactive environment, role overload, which is a definition that comes from Linda Duxbury, who actually reports that 3 out of 5 healthcare workers suffer from role overload. What is meant with role overload? It means too many competing demands and too many roles, leading to too much work and not enough time. I think this is a very important component for oncology social workers to look at, especially since we do have a lot of skills, and oftentimes as individual workers we are appealed to use all of those skills, sometimes to our interest and sometimes not. Fluctuating boundaries, loss and mortality, witness to pain, suffering, and trauma. And more as we conduct more research, balancing compassion with evidence-based interventions and problem solving in the context of uncertainties. Let's just take a step back and look at an overview where the research has gone the last 3 decades. Some theoretical background. In the 70s, Richard Lazarus posed a lot of research in the area of psychophysiological approaches to stress and coping. And this inspired, initially at Harvard, but nowadays has grown to a tremendous growth industry. It's inspired many to develop more mind-body techniques. And we've taken some of those in our field as interventions. Think about Benson relaxation response, but also think about mindful interventions. Then there is a shift in the 90s where finally there is much more interest in the trauma that professional helpers might experience dealing with people who are traumatized. And Charles Figley was a leader in that domain, a traumatologist in background, specifically focusing on models to test and measure some of the trauma experienced by professional helpers. And he coined the term compassion fatigue. Someone who studied with him and then took the work further, Dr. Stam, also developed a concept of compassion satisfaction, the reward we get from helping others. He found especially that professionals who work with others, they enjoy what they do, even if there is distress. And the suggestion is made that distress probably operates on a continuum between compassion satisfaction and compassion fatigue. So ideally, there's to be a balance between those two components. These quality of life scales that Dr. Stam especially developed and refined are valid and reliable measures, and they're free on the internet, and they're not hard to fill out. You'll find them on the resource list. So let's have a closer look at those concepts. We have professional quality of life, compassion satisfaction, compassion fatigue. Compassion satisfaction boils down to the pleasure that we derive from doing our work well, being connected to clients, to colleagues, to our work setting, or connected to the greater good of society. One feels like one makes a difference and feels successful. Compassion fatigue is related to burdens of caring, the negative aspects of providing care to those who experience stress. There are two parts to compassion fatigues, roughly. One part is more related to the trauma of the clients we help, called secondary trauma. It comes more out of empathy, basically. It boils down to being affected by the suffering of others when helpers are strained or fail to help. And as a result, they may suffer themselves. There are no specific data on oncology social workers' levels of secondary trauma and percentages. And even that we may not deal with the horrors of disaster zones that some of our other colleagues in the field experience, we can safely assume there is a significant group of patients who experience the cancer experience as extremely traumatic, and that for all of us, that it can have an effect on us. Burnout is also a factor of compassion fatigue, but more related to organizational issues, and oftentimes result in feelings of helplessness, difficulties to do one's job effectively, being out of touch with oneself. It usually comes on gradually, cumulatively, and we'll go more in depth about these concepts and see what we can do about them. On an aside, the concept of secondary trauma may have been defined more in our culture in the 80s. The concept itself, without naming it as such, already was touched on in Western Europe about 15 to 20 years post-war, when behavioral researchers discovered that the children of those who had extremely traumatic experiences during World War II were affected and experienced secondary trauma as a result of living with parents who were really traumatized. Also, all of these phenomena, one might think, oh, this is a hopeless situation, all very negative. It isn't, because they are part of our reality of helping others. It's part of our territory, and we all struggle with it sometimes. If we don't, there might be a problem. If we do too much and don't find resolution, there might be a problem also. So on secondary, or also called vicarious trauma, there are a number of components. It occurs in the context of helping someone with trauma. As we said before, it's related to an empathic response. Excessive empathy can lead to blurred boundaries. Sometimes there are personal contributing factors. Having had a traumatic history of one's own makes one more vulnerable. And we all know those situations where we've experienced cancer in our own family, and we might meet a patient reminiscent of that situation, and we have to work harder at our countertransference. Then there are affective and cognitive components that are very strong once it gets more extreme, resulting in not wanting to deal with certain patients or not being able to sleep well, feeling irritable, and you just can't stop thinking about a particular patient situation to the extent that it just takes over your life when it gets extreme. By chronic and cumulative exposure without resolution, it definitely can become a problem both at work and at home. And there are behaviors and emotions. We have been very good at creative models dealing with countertransference. And as a result of that, we are very able as a profession to handle secondary trauma if the right supervision is in place. It definitely, in our profession especially, is really critical that there is a proactive clinical supervision component. And as I said before, we have many creative models to that individual group. And from the traditional psychiatric model of countertransference, we've developed some very interesting models that are very helpful for us. Then debriefing can be very helpful too. And we can think about debriefing in two ways: ad hoc, spontaneously approaching a colleague and dealing with the situation, or more formal. And more formal debriefing can include critical incidents debriefing as well, and is scheduled ahead of time. Lack of adequate supervision sometimes encourages for more informal debriefing than necessary and helpful. Because although it is easy to run into a colleague and play by a situation, it might not always be their right time, and especially when it is a very traumatic experience for you, it might throw some trauma on the colleague. And individual psychotherapy can be helpful when the trauma enters a more personal domain and doesn't get resolved through clinical supervision. I think the most important part is to recognize your own symptoms and develop a warning system and being in touch with your stress signals. So when we go back to burnout symptoms, and this comes from the Maslach burnout inventory. Maslach developed several burnout inventories, actually. This one is from the Human Services Survey. We look at symptoms of emotional and physical exhaustion, depersonalization, feeling detached from what one's doing, feeling a reduced sense of personal accomplishment, and it affects thinking, mood, somatic areas, behavior, and arousal states. And with arousal states, I mean sleeping or irritability levels. It also evokes a sense of loss, especially from loss of control, because burnout is so much related to environmental conditions. Burnout often is accompanied by a tremendous sense of shame and doubt and a sense of failure. So as mentioned before, there are strong organizational components to burnout. And burnout can be a major factor in turnover or an intention to leave the job. Unfortunately, in our profession, there is not enough research and data available on staff retention, which would be very helpful, especially in this day and age as we constantly undergo all these changes in the environment, being it the larger environment in our society on healthcare delivery, as well as in organizations with having to do more with less. Maslach developed a scheme in what areas those organizational components lie, and these are the ones where there is a lack of a fit on workload, control, on reward, on community, which has to do with the level of connectedness that one feels to oneself, colleagues, the organization, to the greater good, to fairness, and also values. If there's little sense of purpose or meaning or ethical conflicts, this happens sometimes in organizations where there isn't that much talk about value and what counts the most. AOSW is launching a project in the near future over the summer on burnout, and will ask members to fill in a survey. And I encourage all of you to take part in that survey. It'll be very helpful to collect specific data about our profession. We spoke about the professional quality of life scale developed by Dr. Stam, and it's available in a very helpful manual that can be found on the web and was published in 2010, all up to date. It's a very objective type of scale. And why would we use a scale like that for ourselves? Well, it identifies what goes well and what doesn't go so well for us. It gives an opportunity to review personal situations and our work environment. It also puts a mirror in front of us to accept those things that are imperfect, that we can't change and need to live with. It gives us some material to develop a warning system. And it also gives us a platform for change and monitoring change over time. I think it is increasingly more important to use some more objective instruments to look at these issues. And a lot more research needs to be done in our own field. So when we look at the professional quality of life scales and the results, we see a number of options. If we measure burnout level, compassion satisfaction, and compassion fatigue at a high, medium, and low level. And we can go to some literature from Dr. Mathieu, who gave us some more specifics about that. She also developed a manual. It's a Canadian researcher from Toronto. The manual is called the Compassion Fatigue Workbook. It came out 2 years ago. It has a lot of very helpful exercises and specific topics that you can look at on a day-to-day or week-by-week basis. I highly recommend it. It's very thought-provoking. So how to interpret those scores? Well, the two first ones are very obvious. Like the first one, doing well, low burnout, meaning you work in a nice organization that works out for you, low compassion fatigue, and high compassion satisfaction. You like what you do, and there isn't too much stress related to the clients you work with. It's a great opportunity to offer CEUs when you're a manager to a worker with this profile, for opportunities for growth. And a person in that situation is probably very positive influence on others. Then the second one is also very obvious. A high burnout level, no fit with the organization, high compassion fatigue, a low compassion satisfaction. An individual in that situation obviously should look at changing careers. The third one is more in the domain of organizational issues. High burnout, low compassion fatigue, which is good in some way, and high compassion satisfaction. So if that high burnout in the organization can't be addressed, then you might consider changing jobs and go to a different organization. The fourth one is more at the individual level. Low burnout, good organization, supportive to work in, high compassion fatigue, moderate compassion satisfaction. Give some space to stay and manage stress, especially since there's support in the organization. The last example is more related to having little satisfaction with the type of client load or kind of setting that you work in within an institution. So one might want to look at changing assignments. And this can also happen to people who really love their work, but they just need a change of scenery for a change. So they might switch from radiation oncology to outpatient chemotherapy, etc. Well, what can we do about prevention of burnout and compassion fatigue? Where do we have control? Yes, a reasonable caseload is critical. And we know we're all very busy. We need to develop instruments to quantify what we are doing so that we can define what is a reasonable caseload. A good beginning has been made by looking at distress factors and defining a formula based on patient distress and how much it takes in terms of staff time to address those. Much more needs to be done in that department. Regular supervision, especially clinical, very important. Something we're very good at. Periodic professional checkup, good for anyone, regardless of whether you love your work. A supportive work environment is also a very important component, especially for burnout prevention. DC and Ryan, and you'll find this on the literature list, they developed a theory called self-determination theory and mentioned 3 needs to improve health and safety in work setting. One's autonomy, the second competence, and the third relatedness. Something to think about. Processing with peers. We do a lot of commiseration and problem solving on SWAN, very powerful methods to balance human concerns and evidence-based practice, to always be aware of how we are connected socially at work and outside of work. Although hard to quantify, we all know what an underlying sense of optimism is, and to value a healthy personal lifestyle, recreational, physical, and spiritual. Physical fitness does count and has an impact on how we do mentally. This looks like a major shift to jump from the previous part of the presentation to the Affordable Care Act. But it really isn't, because the Affordable Care Act is changing not only the level of compassion we have in light of resolving health disparities at a larger macro level, but it also is affecting the way our institutions are responding to the Affordable Care Act implementation. And in there are numerous new roles that institutions that deliver health care have to take on in order to comply and reach out. So we can have a reactive or a proactive response to it. As we mentioned before, to have a level of autonomy and control is really critical in terms of our occupational health. Zabora hit on this very well in one of the NASW bulletins of last year. This is a very good information source to check on a regular basis on issues related to the Affordable Care Act. Highly recommend it. The CARE Act will put a much higher demand on, has already, on accountability and evidence-based interventions. And several of the accrediting agencies are already asking, as per now with the implementation, for matrices and outcomes and to demand to create those in order to be re-accredited. So the question is then how to redefine our professional demands in this environment. Well, there are a number of areas that are really very typical to social work, especially areas related to health disparities, to deal with the disenfranchised in our society who have gotten greater access, even that affordability component hasn't been worked out. Access has definitely increased tremendously. And this is where the bread and butter of social workers lies, to deal with those who are disenfranchised. It also includes a specific appeal to teams, something we are good at. So we are definitely in a position to take leadership around these issues, especially around injustice. So I'm asking the question, what new roles will we have? Without being able to answer those exactly, just wanting to instill that thought in you, which new roles, and especially to instill that thought in relationship to overload and career options and changes for oncology social workers. We can, as individual social workers, take on more roles because we have the skills, or we could think more at a larger level where there will be more subspecializations where social workers take on more leadership roles to deal with these issues. My tendency would be to be optimistic. NASW is publishing quite a bit about this. And again, be helpful to stay in touch, even by only reading the bulletins. So what are some of the conclusions and food for thought I'd like to leave you with? Well, for professional self-care to be effective, we need to distinguish the organizational from the personal issues so that we know where the problem lies and where we need to work on the occupational stress. Also, that opportunities for personal coping strategies have to be in place for all oncology social workers in their respective work environments. If we apply more evidence-based tools, as we have done with the stress in patients, we might be able to clearly identify and justify standards and requirements for our own occupational health and safety in our jobs. I think this is a very, very important area, and probably the highest priority, to be able to indicate what we mean with staffing needs. Although there are some evidence-based materials, we need to do more in our own domain. The schools of social work, having paid very little attention to occupational health issues, must prepare future professionals better by offering training and also emphasize the value of a healthy lifestyle as a professional helper. This in addition to clinical supervision. A question, do you know whether your organization has a plan in place for an employee's ongoing emotional health and safety in addition to the usual orientation and training or EAP? An interesting thought came to mind when I went through this area and thought it through a little bit more, is that so often we are called in to help our team members from other professions to deal with their distress. But is there really a model and a plan for that in your organization? Oftentimes this happens ad hoc, and oftentimes very well provided for. But do we know what the plans are for our support in the organization? Being an active participant in the social networks in a community and organization, and especially within one's peer group, form a component of ongoing occupational health and self-care. And did you know that the Association of Oncology Social Work is sponsoring a number of projects that address occupational health? Some through our research group, and I hope that you will explore our site and participate in anything that we offer. Remember, the next project will be on the Maslach burnout inventory. But as a final statement, I would like to say that I and many others I know have found to be oncology social work a tremendously rewarding career, with exposure to tremendously intense experiences. And personal commitment and compassion are intertwined with evidence-based clinical intervention. That compassion, fatigue, burnout, and secondary trauma are part of reality and do not have to be bad as long as we deal with them appropriately. From it we grow. and therefore tending to our occupational health and personal well-being is never a luxury, but a basic necessity to safeguard ourselves and our ability to contribute to the psychosocial well-being of those we serve. Thank you very much, and again, feel free to request slides and use them freely within your own settings.